Good evening, everyone. Welcome and thank you for joining us for this exciting webinar. My name is Suresh Sharkande, for those of you who don't know me, and I am the head of the faculty and strategic advisor at Zephyr Sleep Technologies. I'll be the host and the moderator for tonight's webinar. Tonight's webinar title is Treating Sleep Apnea in the Post-COVID World. We will be talking about the impact of COVID-19 on our patients, on physicians and on dentists, and we'll be talking about some of the concerns that have been coming up with regards to the utilization of CPAP, traditional sleep apnea treatment during this time. Also, Dr. Remmers will be discussing how this can be an opportunity for oral appliance therapy to be used more commonly, but more importantly, we'll be talking about how we can make this effective and how we can confidently grow your practice with evidence-based and clinically validated technologies and improve patients' experience through treatment planning for oral appliance therapy to make the treatment predictable and more simple and acceptable by our patients. But before, I have the absolute pleasure of introducing, as I said, Dr. John Remmers. He's the Chief Medical Officer and a co-founder at Zephyr Sleep Technologies. He's a recognized physiologist, pioneer, and innovator in sleep medicine, of course, world-renowned expert in the field of obstructive sleep apnea and snoring. He's the first researcher to elucidate the pathophysiology of pathogenesis of sleep apnea and showing that the sleep apnea is due to narrowing of the pharynx during the sleep. His research, I can go on and on, mostly relates to neurobiology of respiratory rhythmogenesis, chemoreception, and the pathophysiology of control of breathing. And he's really focused on improving the efficacy of oral appliance therapy. And he's a big advocate of oral appliance therapy for the past few decades here. John, I'm just going to mute myself here. The mic is yours, and I'm going to get rid of my video as well, but a pleasure to have you on. Looking forward to this presentation, John.
Thank you, Suresh. Good evening, everyone. I'm pleasure to be leading you through first a bit about COVID and then into how it may influence our therapy, and finally into how we may improve our therapy. I'm going to speak to you mainly as a physician, but I'm a oral appliance friendly physician, but nonetheless I think you'll find some of the things I say challenging. I hope so. COVID, let me tell you a little bit about the infectious disease of COVID. We have a lovely paper from University of North Carolina, and it shows that this crown type of fabulous looking virus is located primarily in the nasal cavity. So if you have COVID, it's primarily in your nose. That's where most of the viruses are. And then if you look throughout the lung, you see a patchy distribution in what we call pneumocytes, only in one kind of cell. And because of this distribution of a heavy nidus in the nose and then a spotty distribution through the lung, led to the hypothesis, brand new, is that aspiration of oral and nasal fluids into the lung, particularly at night, is a significant contributor to COVID-19 pneumonia. That's not my theory. That's the leading workers in the field. That's what they just said. Last week's article published in Cell, leading journal. So I thought you would enjoy to hear that. So already people are saying, what the hell is going on in sleep? We're having some stuff going on in sleep in relation to COVID. Well, there's another little pearl that I'm going to give you. And that appeared about a week ago. It was a study of 1,300 patients hospitalized in France for COVID. And they just simply looked at how they presented, what diseases did they have when they came into the hospital, what were their symptoms and their blood work, and then they looked at when they died. And they found some very interesting associations. So we're talking about death within 7 days of hospitalization. So you're admitted to the hospital with COVID, and then we just note when you die. And if you have a high BMI, you die earlier than other people. Microvascular disease, sometimes you die earlier than other people. But obstructive sleep apnea, it came right out of the blue. It triples the risk of death in 7 days. So threefold increase in the probability of dying after being admitted to the hospital. Oh, that's interesting. So we can put these two together. Maybe micro aspirations when you come down with COVID leads to more seeding of the lungs with the virus, and hence you have a larger chance or greater chance of dying. But right now, it's just an association, but a very intriguing association indeed. Well, I say we ought to all, the physicians, dentists, and all of us need to be more attentive to treatment and diagnosis. And I want to look at some of the treatment options that we traditionally use. CPAP. How does it work? You know this. While awake, your muscles hold the airway open. If you have sleep apnea and go to sleep, these muscles relax somewhat, the genioglossus in particular, and we have a collapse or narrowing, severe narrowing of the pharyngeal airway. If we give positive airway pressure to the nose, the airway pressure gets transmitted down into the pharynx and inflates it, blows it open like an inner tube. It's a collapsible tube, it blows it open. Real simple, and that's what it does. But there's a feature that I haven't told you about. We have air pressure coming from a blower by the bedside. It's generating air, it comes up here, and then it exhausts out continuously. You have a flow out an exhaust port, and that maintains the pressure of, say, 5, 10, 20, whatever the pressure is that you need in here in the mask or interface. That's maintained by this steady flow of exhaust gas. And so when you exhale, the exhaust gas goes whipping out the exhaust port. The velocity goes up. That may change the size and distribution of the particles, and it may also shoot them out into the environment. So we go way out here. So instead of a normal expiration where the exhaled gas would come down along the chin and not be dispersed, here with CPAP, we have the possibility for wide dispersion and a change in the size of the droplets. You might call it even aerosolization. Well, this has been thought about, but we also have some concerns. The transmission by small droplets is unequivocally the most important method of transmission of the coronavirus from one person to another. Maybe even an airborne aerosol. The aerosol is a droplet or a particle that's less than 10 micro. So maybe we have that. We don't know for sure. That's more like measles or TB, but we have droplets, 50 micro and less, that are moving around in the environment and going from one to another. CPAP has been implicated in the spread in long-term institutions, and I'm going to tell you more about that. And so we suggest that that while we want patients who are currently using CPAP to continue to use CPAP, no doubt we do not want to have a compliant CPAP user stop the therapy. We say that CPAP machines probably ought to be restricted. They can be used in hospitals if you have a medical grade filter and people around you have the appropriate protection. So we have a situation here that around CPAP, and let's have a look. So CPAP is not recommended for new cases of sleep apnea because of the possible COVID-19 spread by aerosols out of the exhaust flow. This is our society, my society. I'm a sleep doctor, American Academy of Sleep Medicine. That's my society, and that's what they say. So that's pretty interesting. And now we come that OAT, oral appliance therapy, is an effective alternative that does not spread aerosols. All true. But it may not be the same as CPAP with regard to its being efficacious. So it must be done right. And that's what I'm really going to focus on here tonight. Here we go. Let's start with a bit of public health. Kirkland, Washington, the long-term care institution there right outside of Seattle, nursing home became ground zero, essentially, for COVID-19 in the USA. First responders came to treat some patients who had respiratory problems, shortness of breath, and they put them on CPAP. And they didn't know what they were treating. They just knew these people were in trouble, having trouble breathing, put them on CPAP, and turned out they were infected with COVID-19. A little bit later, 129 people, both residents and staff, tested positive. 35 died. Well, that's not good, and that really set up the alarm bells about CPAP. It goes back, though, to 2023, where SARS was being encountered in Toronto. This was a virus that's very much like COVID-19, like a coronavirus. And we had transmission occurring in the ICU, and mostly healthcare workers were getting infected. 20% of the global cases were in healthcare workers, and in Canada, 43%. It turns out that 69% received mechanical ventilation using, to some extent, the positive airway pressure, either a non-invasive ventilation or just CPAP. And the healthcare workers were using all the appropriate protective equipment and everything. But it turned out that there was the real implication with the positive pressure and the exposure to respiratory secretions that generate aerosols resulted in this SARS transmission to the healthcare workers, and half of them died. So that's been published back there 10 years ago, but it came to life again with COVID. So here the problem with CPAP. Because of the possible spread of COVID-19 infection, CPAP is not recommended as frontline therapy for many patients. If not, then where do you start? Well, we have then the notion that the oral appliance therapy might be prescribed as first line therapy for obstructive sleep apnea in the COVID pandemic. That comes from a very conservative group that most of us belong to, or many of us belong to, the American Academy of Dental Sleep Medicine. Says, oh, maybe you ought to be thinking about frontline therapy being principally oral appliance therapy. So carrying on here, I ask you, what's wrong with this announcement? I think there's something wrong with it. And I think that the notion that oral appliance therapy might be the preferred frontline therapy in the COVID epidemic for treating obstructive sleep apnea requires or presumes that the oral appliance therapy is as efficacious as CPAP. In other words, are we giving somebody just as good a therapy or not? And well, we're not, unless we do it in a proper way. So here's the problem with oral appliance therapy. First of all, it doesn't treat all patients with sleep apnea. And second, there's no standard practice that has been established. Everybody's got their own method for doing bite registration, for advancing a custom appliance, and it's all a bit of guesswork, I submit. So we really aren't the same as CPAP. And this becomes particularly apparent when we deal with severe obstructive sleep apnea. Of course, you know that CPAP treats 100% of patients, including all patients with severe OSA, whereas oral appliance treats only half of patients with severe OSA. And we have this blind titration, numerous clinic visits, longer time to treatment. It's not an equivalent therapy. And so only we can make it become an equivalent therapy if we use the treatment planning that's provided by Matrix Plus. So you'll hear a lot about this now. So oral appliance therapy requires a valid predictive set of information. We have to have that if we're going to make it equivalent to CPAP, both in efficacy and in convenience of administration. We can get 100% efficacious therapy but we have to use Matrix Plus. It's the only way to do it. If you want to treat all sleep apneics and have a 100% efficacious rate with severe sleep apnea, the only way you can do it is with a Matrix Plus that provides predictable, efficacious therapy in 1 to 2 visits. The actual dental aspects of this, Suresh is going to go into toward the end. So I'm just going to deal with it from a medical physician point of view, if you like. And I'm an OF, that's an oral appliance friendly physician. I am 20 years working on it, but I maintain that oral appliance therapy is not equivalent to CPAP unless you use a Matrix Plus as guidance. Here's the results of a trial that we did, 320 patients, and we did a Matrix Plus test on them all and fitted them all with a custom appliance. And here's the results. And I'm showing here just number of patients. And on the x-axis is the efficacious position, going from 0 up to 100% of full protrusion. And you can see that we have different numbers and different categories, but everybody's different. Some people are down here get a therapeutic response at 40%, and some people at 100%, and some, the reds out here, not at all. 20% of all our patients, 30% of all our patients show no efficacious therapeutic response with maximum protrusion. So they're off here, they're off the scale, but everybody's different. And it's that difference that you can't determine by clinical features, the BMI, how long the hair is, I don't care, whatever you want to do. It's been studied time and again, and you can't predict what position you need, nor can you predict whether the patient's going to lie out here in the red or be in the blue. That's what Matrix Plus does for you. So you might, here's the group that's non-treatable. We certainly don't want to be starting them on oral appliance therapy, whether it's in COVID or any other time. But then in addition, if this is our starting point here, we can see that a lot of people are going to be over protruded. All these people to the left over here, that's about half of the patients, are going to be over treated if you start here with your bite registration and titrating the custom oral appliance. And there are other people way over at the top here right that are near 100% that may not tolerate the treatment. And you didn't know that going in. So you have no idea whether you're dealing with the over protruded group or the group that's near the limits of protrusion. And maybe 20% of people right here in the middle, you're right on the nose and you can do a good job. Well, that's hardly precision medicine, and that's what we want. So how do we avoid these treatment failures? Treatment planning, we call it. I want to deal with that in some detail here. We go from awareness, diagnosis, treatment planning, treatment, and treatment follow-up. I'm going to focus on treatment planning. This is through medicine and dentistry. You all know this. The goal here of the planning is to customize and optimize the treatment. So treatment planning, though, requires valid predictive information. You can't make it up. You can't just say, I'm going to do this, and there's no evidence for it, no evidence to support it. You got to actually know what you're doing and know based upon evidence that this is the place to begin the titration. This is the place to expect an efficacious response. So in CPAP, just by contrast, I'm going to show you what the competition does here. What does CPAP do? Well, if as a physician making a diagnosis and I want to start somebody on auto CPAP, just on CPAP, I first send them over to the respiratory therapist who's been trained to do this, who's going to give the patient a trial of auto CPAP. The pressure is being adjusted up and down throughout the night. And there's a multi-night trial of auto CPAP. From that, we find out whether or not the patient can tolerate the CPAP. We have an optimal pressure that we learn about, and we can learn then about an interface that can be used. That's all in pre-treatment planning. Well, with oral appliance treatment planning, we use the matrix. And again, we have an auto titration study that's done, and the results of that allow the dentist to know whether or not to proceed with treatment and to know the configuration that will lead to an efficacious response. All of that is done out of a test carried out during sleep, just like auto CPAP is a test carried out during sleep. So to have success in your treatment planning, you have to know the information, obviously, before you begin. And you deploy methods that are clinically validated, for sure, evidence-based, and that's what's lacking. Nobody else has evidence-based approach or methods. And finally, FDA cleared. FDA cleared for this purpose. That's what we need. And now, if you use that, you can gain the trust and respect of the sleep physician. I can tell you, I know why they are suspicious of the dentist and his therapy. So do we have a method for treatment planning that is clinically validated, evidence-based, and FDA cleared? You bet we do. It's called Matrix Plus, and it consists of a little body-mounted computer, a bedside tablet, and it allows us, with a sleep study carried out during sleep in which the mandible is protruded and retruded throughout the night, allows us to predict who's going to respond and how to carry out the treatment. Here's an example of the evidence. We've carried out 3 clinical trials, and so a lot of evidence here. But this gives you an example. The result of the Matrix Plus test, these were carried out on 60 patients, 65 patients, and there's divided into the 65 patients divided into 2 groups. Those who were predicted by the test to experience therapeutic success with a custom oral appliance, and those who were predicted to experience therapeutic failure with a custom oral appliance. So we divided them based only upon the test into 2 groups. And let's look at the successes over here. They're a joy. I'm plotting the ODI. That's our preferred index for severity of sleep apnea. And we say, look, if we can get the ODI less than 10, that's therapeutic success. Less than 10 with a custom oral appliance, that is. Well, at baseline, with nothing in the mouth, you can see that we have a distribution going from about 10 up to 110, all in the predicted successes. So all these people were predicted to be successes. Here's their baseline values. And look at what they were with the custom oral appliance in the mouth. Bingo, all of them were less than 10. And the mean value over here was 5.8. So we hit home run. It's just no doubt about it. Everybody whom we predicted would succeed, they were successful based only on the test. Over here, we have those predicted to experience therapeutic failure. Again, similar kind of distribution, ODI from 15 up to 100. And you can see in the red lines that none of these patients in red had therapeutic success. They all were left with a custom oral appliance at outcome with an ODI or AHI, didn't matter, greater than 10. Some didn't improve at all, some improved a bit, but really you're going to agree they're not successful. The blue lines, those are our errors. We have 4 false negatives, and they did have experience of therapeutic success. That is an ODI less than 10 with the custom appliance in place. So this is great prediction. It's far and away better than anything else that's available. And I want to just mention that what it really provides you is certainty. When you begin, here the certainty is right here. It's that all these patients, and it's about 70% of the patients, they all zoomed right down, and with the oral appliance in place at an efficacious position that was predicted by the test, they were all in great shape and were therapeutic successes. So this is our really our home run that we hit for you, and the test does that for you. We also have the treatment planning related to the bite registration, or the configuration, I call it. How should you set up the custom oral appliance? And the results of the test tell you how much protrusion you need when you do your bite registration. And that's plotted. The prediction is shown on the x-axis, and the actual efficacious position that turned out toward therapeutic success, that's on the y-axis here. And if you each point is a patient, the points lie on the line of identity, it means that the efficacious position was exactly the same as the predicted efficacious position. I'll say that again. The outcome position that was required to get therapeutic success was exactly the same as that which was predicted. We missed in 6 patients. Here they are right up here. They lie off the line. They required a bit more protrusion to have an efficacious outcome. So 85% of the time, you spot on. And Dr. Sarkanda will go into this a little bit more here in a minute. But so the test result allows you to plan. You'll know in advance whether this patient is going to experience therapeutic success or not. And you will know in advance just how much protrusion is going to be required. The median value is around 70%. So if you start a patient, if your habit, for whatever reason, is that you start your protrusion adjustment of the custom appliance at 70%, well, you can see you're going to over protrude half of these patients. And that's, I think, a very important feature. Okay, certainty. I want to just say in closing that we're trying to take the guesswork out of all of this, and I think we have. At the present time, the standard treatment or the old-fashioned treatment is very simple. You take some method that you use. You just take all patients that have sleep apnea. You don't know whether they're going to be a responder or not, whether they're going to have a good therapeutic outcome or not. And then you do some method. It could be, I don't know, you shock the nerves, or you try to see if people can snore when they protrude their mandible, or they just do a kind of a Goldilocks thing. I'll find a comfortable configuration, whatever you want to do. And you have your own methods maybe. And it turns out that they are unvalidated. There's no validation for that. No, by that I mean no published evidence. Prospective clinical trials. We've got 3 prospective clinical trials, and you can see the accuracy. I've just shown you the accuracy that we have. So I'm just trying to say you can rely on this. It takes the guesswork out of this. So with that, I'd like to turn this over to the real dentist and have him go into more detail about how this fits into dental practice.
Well, thank you, John. That was fascinating. I'm sure we're going to come back to it. I'm not going to make a lot of comments on it yet. I'm just going to share the slides from my screen here, just to make sure this is working. And it seems to be up. I like where you kind of left this, John, with certainty. But basically, what we're talking about here sounds to be basically precision medicine. This is a term that we keep on hearing every day. It's about finding exactly what therapy works for what patient and what dosage of therapy is going to work for what patient. Just knowing that precise dose and type of treatment for a certain person. That's where the medicine and dentistry is moving towards. But precision medicine in general, it's not a new concept either. If you actually think about the technicality part of it, as dentists, I want to talk about that. We are never okay with having, for instance, placing a crown with only 50% success rate. If we were going to place a crown, or our root canal treatments were only 60 or 70% of the time successful, most of us would be out of business. I would like to say that. And somehow when it came to sleep, it started on that notion of, well, 60, 70% success is good enough prognosis for us. And as I said, technically that would be considered a very guarded or poor prognosis in any other treatment that we do in dentistry. But you know, that's what we had available, and that's what was available. But now we have better, and I do want to talk about that. Before I get into the whole notion of COVID, I do want to talk about why sleep in general. And that's one of the things. That's how the dentistry has been changing in the past decade or so, perhaps past 2 decades. We're moving away from procedure-based dentistry more towards wellness-based dentistry. Basically, the consumer behavior is changing. We're seeing that every day in our clinics. People are not necessarily only coming in for getting a filling or a crown done. They want to know what that crown is going to do for the quality of their life. They want to know how it's contributing to their overall wellness, how is it contributing to their total health. So consumers know exactly what they're looking for. They want things that's going to make the quality of their life better, or perhaps increase their quality of the length of their life. So it's changing that way, and we got to keep up with that. Otherwise, our businesses are going to be not going in the right direction, for lack of a better term. Also, a lot of patients know exactly what treatments are available to them. When they don't get that offered to them, they get archaic treatments offered to them in our clinics without any technology-based workflows and any digital workflow. We are not giving them the highest and best quality of care that is available for them. So in general, if you want to stay relevant in the whole world of dentistry, we got to keep up with the consumers' demand. And the consumers are demanding, as I said, total health wellness related materials and procedures, and also predictable technology driven workflows. And this is exactly where sleep fits into a dental practice. So even prior to COVID, that was something that you could have added to your practice, and you'll be right up to date with where the industry is moving towards. Especially, I want to be really put a little bit of emphasis on that, the way it's being done with our treatment planning through Matrix Plus and Zephyr Technologies, because it allows us to exactly tell the patient how to treatment plan is going to go for them over the next month or two. That becomes a little bit more important, of course, in the world of post-COVID. COVID has changed everything. Everybody's worrying in the dental field right now about, okay, what's going to happen to my practice with all aerosol? Everything that we do in dentistry pretty much creates aerosol. And not only that, you kind of exaggerates the impact of where the industry was going, and as I said, is the consumer's choice. So in the world of COVID, of course, what we want to be working on is aerosol-free procedures. And sleep, again, is one of those procedures that they can add to your practice, and it is not aerosol filled. Of course, there's some procedures in sleep that require you adjusting appliances, but mostly it's a straight handpiece acrylic burt, which doesn't really fall under the aerosol generating procedures. So if you're looking for a procedure that allows you to diversify your dental practice, sleep fits right in there, and allows you to take a break in between patients from all those horrendous and absolutely necessary, of course, PPEs and having an N95. Imagine going between 20 to 30 patients throughout the day wearing an N95 mask and a full-on gown and the respirator and the face shield. So it is very important to keep that in mind. You can add a procedure that doesn't require a lot and actually helps you with your daily schedules and gets you to the next phase. But how is it different with the way we do our treatment planning? And that's very important. When you look at sleep the conventional way versus the way we do it, every visit counts. Every time a patient is coming back to our clinic today, it is a possibility of creating aerosol. Even if they're not creating aerosol, even if they're coming back for 4 or 5 visits just to see us for titrations, that is another 4 or 5 visits that we have to turn the rooms around. Our staff have to change their PPE. We have to clean the room. We have to spend time with them, and we run the risk of multiple contacts with more patients. So the more we can minimize the number of the visits for a patient that comes back, the better we are in terms of efficiency and accuracy. And that is exactly what Matrix does for sleep medicine. In our studies, as you know, John, about 75% of our patients required basically one follow-up visit only. After we delivered the appliance, they only had to come in once for us to make sure the appliance was comfortable, there was no TMJ issues or any side effect issues that had to be dealt with. Versus if you were to do it the conventional way, in average, I would say it requires 3 to 5 visits. A lot more important in the world post-COVID, because again, every patient that walks through your door is costing your practice and your clinic a lot of money in PPE, but most importantly, it's putting your staff, yourself, all the other patients that are working in the clinic at the risk of perhaps being another person that could be populating the disease in that sense. So let's look at some of the data that we've shown. This is from our studies. I know in this it says numbers was 38, but you know, John, in our second and third studies, we had similar numbers, and we have a lot higher numbers, about 300 patients now. And as I said, 75% of patients required only one visit, and the other ones, you had a few that needed to come back after 1 or 2 visits to deal with the side effects. Some of you might be wondering how are you putting the appliance right at that target position? What if the patient requires 80 or 90% protrusion before they're actually going to be at the efficacious point? Well, it appears that when we do that, the patients tolerate oral appliance therapy very, very comparable and perhaps even better than the conventional way. We were worried about putting the patient right at the target of 70% and having more side effects. It appears that's not the case. We have some hypotheses on that. We believe that when you take the bite right at that target position where the airway is going to remain open, you're helping the patient perhaps sleep better, you're getting their sleep parameters right in the right position, but also we are putting the yaw, pitch, roll, all the different aspects of the bite registration right at the right position, at the final position. Because in other conventional methods, when you start at a starting point, doesn't matter how good we are with your bite registration, what do we do from that point? We're going to start moving the mandible forward, and we get to a way we walk away from it. We spend hours and hours and times and whatever finding that position, and then we say goodbye to it and walk away from it. What if we just knew where we're going? As Yogi Berra would say, if you don't know where you're going, you'll end up someplace else. So let's figure out what we do. And that's not a new concept in dentistry. Every time we treatment plan, we talk about this. You got to know where your destination is. You got to know what the diagnosis is. And the treatment, then you design that treatment. And that's exactly what the 2 parameters that Matrix gives us allows us to define that road. It tells us whether or not they're going to respond, at what position, so we can design our treatment for those 2 parameters and going from there. But again, I want everybody to recognize that the fast relief, well, we've noticed a lot of patients that required 80% or less protrusion. And I don't want to give a misperception here. About 50% of our patients required 60% or less protrusion anyway, some of them requiring just a stabilization of the mandible. But in general, if they required 80% or less, we were able to go right to the target position without increased risk of discomfort or non-acceptance of the treatment. And if they were more than 80%, we inserted them at the 80 and slowly moved forward in that sense. So what we're really talking about here, we're talking about efficiency. We're talking about efficiency both in terms of quality of care and time and in terms of your business. What we're talking about here is less chair time, better treatment, better patient experience. Here's a graph that's showing to us basically how if you were to start at a 50% titration point, which, you know what, if you're not having a guided titration, it's a good point to start because you don't want to over titrate the patients. But then you're running the risk of having to bring the patients multiple times because it will take you longer to get to that end point. Well, some of you may want to even start further back because you're really worried about over titration. What we've seen in our studies show that if you start at 30%, it takes almost 149 minutes, 150 minutes to get to that position. And if you want to be more aggressive and you're starting at 70%, well, you may get to that final point faster if you ever get there, of course, if they're a responder. But it still requires 3 appointments, and you're running the risk of over protruding a lot of patients that didn't require that 70%. So overall, we're talking about treating more people, saving money on unnecessary titration, better patient experience. I want to keep on going back to that, and driving referrals with excellence in patient experience. What does that mean? That's basically differentiating your practice. You got to show why your therapy and your method is better, and that's what we believe that treatment planning is going to provide for us. I don't want to take, as I said, a lot of time on this because I know there's going to be a lot of questions, but I thought it would be important to put it in perspective of how it's actually going to impact the day-to-day clinical workflow. It's I don't want to say a better way of doing anything. It's just a different way of doing it. In my opinion, it's the only way I do it in my clinic these days, because once you get to that level, your patients are going to demand that from you. The physicians referral that are coming to our clinic, without an exception, every one of them is requiring us to follow these protocols, and I would highly suggest most of you to explore this as well. With that being said, as you mentioned, John, I feel like COVID-19 is really emphasizing the need for alternative for CPAPs. We've discussed that for many years now, but this could be our golden opportunity to actually make that paradigm shift. But it's only going to be effective if we are having that evidence-based, validated clinical protocols, and OAT needs to be as efficacious as CPAP. And it's only possible when you're using Matrix Plus and treatment planning in that sense. With that being said, I want to open the webinar for questions and answers. I will pull up the Q&A. And John, if you want to add any comment to that one while I'm pulling up the Q&A, please go ahead. And thank you for an eye-opening presentation, of course.
And thank you very much. It was a lovely presentation, Suresh. I could second what you said about the physician referral. I would only refer my patients with sleep apnea to a Matrix Plus qualified physician, dentist. That's it. There's no reason to do anything else. Why would I subject my patient to a lot of guesswork, a number of visits, longer treatment, only to find out that maybe he's got severe sleep apnea and doesn't respond. So I think it's the relationship between the dentist and the treatment person, the dentist and the physician, is greatly enhanced by having a test that really provides information for everybody. Everybody knows what we're getting into: patient, physician, and therapist.
Yeah, it's very important, John. We have a question here. It says, in your opinion as a physician, of course, what would be your recommendations for patients that are currently on CPAP therapy? This is not a new patient. This is a patient that is already on a CPAP. What I'm assuming that's what exactly they're asking. I've been asked that question.
Great. Terrific. That's the terrific question. So I start by saying it's very hard to get people to use CPAP consistently. And once you get somebody using it, they're happy with it, they sleep well with it, and they're completely treated, watch out. We don't want to mess with that. We don't want to disturb that. So my initial approach would be to say, oh, if things are okay, probably it's just fine. And then, of course, I'd want to explore the clinical aspects. Who else lives in the house? Or is this in perhaps a long-term care facility? Exactly what is the situation would become very pivotal. Obviously, if somebody was, let's say, a frontline healthcare worker and uses CPAP every night, and then there's a mother or a father living upstairs who's over 70. Wow, either you want to move out or you might want to stop using CPAP. So depending on the circumstances, and really genuine fundamental discussions, and I would certainly have them with the physician. It's important that the physician participates in any decision about moving from CPAP to some other therapy. So that's a very important but very dicey type of situation. A bit different than somebody who just says, "Oh, I've got sleep apnea now. I just discovered that, and given what you've already told me that maybe I'm more at risk for complications, I'd like to get it treated, and I don't want to go home and start blowing aerosols and viruses all over my house. I think I'll go with an oral appliance." So hopefully that's the situation you're going to encounter mostly, but I'm sure you will encounter occasionally the person who says, should I continue with CPAP? There's no easy answer for that. I want to caution you that in general, the idea that CPAP is spreading the disease, moving the virus around in droplets, this has not been well established. I've presented you the evidence, and it's that kind of evidence. That's it. So it's fair to say this can still be considered controversial.
Okay.
It's fair to say that you need to be cautious and need to be interacting with the patient's physician. But on the other hand, there is the results that I've shown you, and in addition, we have the recommendations coming from the sleep societies, and so I hope that answers your question somewhat. And if there's an individual case that you'd like to chat about, give me a call for sure. I'd love to talk.
Would it be fair to basically say, of course, it's case dependent, like a lot of different things that we do in medicine and dentistry, and requires a proper clinical evaluation, right? Again, going back to having that precision medicine and proper treatment planning, to me, that's even part of treatment planning, but not one size fits all in a sense. We got to understand what it means to that one patient without generalizing it without strong evidence.
But and I want to emphasize, CPAP's a little different than other treatment. If you were just taking a medicine, you could switch from one medicine to another. That's one
Yeah,
thing. But this is different. Uh,
yeah.
I don't know how many of you out there are actually using CPAP. I'll bet it's probably 20% or something. But you know that it's not easy. You know that you may have severe sleep apnea, and this is your way to control it to avoid a heart attack and a stroke. So sleep apnea is a fatal disease. It has cardiovascular risks that are depend on how severe the sleep apnea is. And no doubt, if you have severe sleep apnea, you want to get that treated and treated well, not partially treated. So it's got to be treated well. That is to say, it has to be therapeutically a successful treatment, and that to me means an AHI or ODI less than 10. So this is all uh, difficult stuff, and if a patient has achieved that and is doing fine, be careful before you rock the boat. Okay,
Yeah.
be careful before you rock the boat. So uh, and do so with a lot of discussion with the patient and the physician.
I actually got a follow-up question to that. How do we get more, because I know probably a lot of people are thinking about that. How do we get more physicians to start understanding what you just described? That's probably what a lot of dentists are going to, and get them open-minded to it. And other question, that's just as a follow-up to that, do you think it's going to change the way dentists are able to perhaps dispense or diagnose level 3 testing in the sleep studies? And do you think that's going to have an impact on the diagnosis level and the screening and diagnosis level as
Let's start with the first part of the question. Uh, I think you have to have a therapy that's based on evidence, just like the CPAP is based on evidence, and then you have to be able to show, but using your method, the the Zephyr Matrix Plus method, that you give results that are actually equivalent to CPAP.
well?
And that is to say, 100% efficacious. You're not going to undertake the therapy in somebody if you don't know in advance that it's going to be an efficacious therapy, and you can get the job done in a reasonable period of time, 1-2 visits, and so on. So that it's the physician will start to listen, will start to respect you as a really high quality therapist, equivalent to the respiratory therapist that he sends his patient to get CPAP. Uh, if you have this, it's what he expects. He expects that you know what you're doing and that it's evidence based. And if you're not using Matrix Plus, you're not evidence based. Whatever methods you're using, guesswork, and that's very disturbing to a physician who's got sitting right down the street a respiratory therapist who will implement a standard protocol, and I'll know in advance how it's going to work out. You can say what you want about compliance and so on. Sure, as a physician, I'm going to worry about compliance, but I can tell you where I want to start. Where I want to start is with a completely efficacious treatment. And
Yeah.
so I think that would be the key. The second part of your question, Suresh, about how this might influence diagnosis, I, I, that's an evolving and regionally dependent question. I certainly am in favor of dentists uh, doing home sleep apnea tests, very much.
Yeah.
As I said, 80% of people are undiagnosed.
Yeah, we got to increase access to care.
We have to change that, and the reason I'm doing this, why am I working with the dentist, it's just because they have the ability, we have the manpower, the skills to do this in the dentist population. But the what about the other chronic disease that has cardiovascular risks. One is diabetes, the other is hypertension. There are only 45% of diabetics who are undiagnosed, as opposed to 80% of sleep apneics. And then you come to hypertension, there's only 15% that are undiagnosed.
Yeah.
Now, sleep apnea has a more significant risk associated with it than either of those other two. So we have a public health problem, and we must get more diagnosis done. And for me, it's not going to be the sleep physicians. There's just not enough of them. It's
Yeah.
going to be the dentist. It's going to be the dentist who is interested and trained and respected by the sleep physician.
Good, good. Thank you, John. Got a question here. This is from Gary Lutka, I believe. Gary is asking about the false negatives that we had in our studies. You showed that in your graph as well, that
Right.
our strength is in our positive predictive value, and we do have some false negative in matrix plus testing. His question is not necessarily clinical. He's asking, what is the hypothesis for the false negatives? I'm assuming what you're asking, Gary, is why do we think the prediction was a false negatives, and have we done any studies retrospectively on them? I'm going to let John answer that.
Oh yeah, no, this is close to my heart, Gary. We've sweated and sweated. We've been working on this particular aspect for, I don't know, 5 or 6 years. Before we had the home sleep test, we had an in-lab test called Matrix, and so here are the hypotheses, and we've not been able to prove or exclude any of them. First one is, and you might say this as a dentist, you might say, oh, I look at those matrix trays and they're clearly bulky and that bulkier than the custom oral appliance that I use. So you're taking up some tongue space. Well, maybe, but we can't show that. And it really, I think, is not a very good hypothesis. The next one is, the patient, when you're doing the test, this home sleep test that you do, he has or she has untreated sleep apnea. And when that's going on, particularly in somebody with severe sleep apnea, and by the way, many of our false positives are in the severe category. Somebody with severe sleep apnea, they're going to have edema back here in the soft palate and around the base of the tongue. And that's going to cause a narrowing. Which one the patient is treated may evaporate, and we would have somebody who was had a prediction for therapeutic failure at the time we did the test, but then when you actually give them and let them use a therapy for a few weeks, the edema goes away, and now they are therapeutic success. That's another one. That's plausible. The the one that seems most likely is to come to the realization that the airway, you're all tuned in now to airway, and that the airway, and it's got an anatomical problem, that the airway is, in fact, it's got an anatomical problem in sleep apnea, but it's embedded in a larger system called the human being. And that larger system has negative feedbacks that control breathing. It has a sensitivity to a disturbance that causes the patient to become aroused, wake up, and start to breathe. So we have other factors that I call systemic factors that very much influence the apnea hypopnea index. And some of these resolve with time. Let's take the loop gain. We've known this for a long time over on the medical side. When we treat some people with CPAP, they have emergent central sleep apnea. What that means is put them on CPAP, and now they no longer have obstructive sleep apnea, they have central sleep apnea. And then that goes away with time. So it's some kind of a hyperactive control system, much like high blood pressure is excessive activity of the blood pressure control. Here we have an excessive activity or sensitivity of the control of breathing. And like with blood pressure, when you treat the sleep apnea, that will decline and go away. It seems to have been caused by the sleep apnea in the first place. So that's the hypothesis that I like the most. I have some evidence for it, but uh, not very compelling. But I believe that in some patients, uh, you can have a very when you first treat them, and particularly if you uh, protrude them a lot, uh, you'll get the idea that they aren't responding to an oral appliance when in fact, and they're not. But the reason is not that you haven't opened up the airway. The reason is that the system is oscillating. The negative feedback system is oscillating, and in fact, we very often see that that's one of the consequences of over protrusion. So I've given you a long answer. I clearly don't know the proper answer. We're working on it. We've continued to work on it. But one of the things that you must know about us is that we are honest. We tell you what we find. We publish our data, and that's what we call evidence. Is when you publish your data and through a peer-reviewed journal, and the experts take shots at you and try to figure out what's wrong with what you've done, and then they finally accept what you've done, and now you have something that you can count on. It's like someone said recently that some people in administration don't accept science, and it was Dr. Fauci. He said, "Well, that's too bad because science is truth."
Mm-hmm.
I thought that was really cool. It's truth. So we try to give you truth.
That's a beautiful answer, John. If I could add to that, I sometimes not adding necessarily. It's just I've always looked at it this way that when you start learning a lot about a sleep apnea, you realize it is a very, very, very complex disease, a lot more complex than a lot of us can even imagine. There's different phenotypes of it. There's a lot of discussions around that today, but relatively it has very simple solutions. If you think about mechanics of oral appliance or CPAP, it's very simple, but it doesn't mean the treatment is actually simple. It's not that simple. The only way to make it actually predictable and safe and easy to access for a lot of dentists is through utilization of technology and digital workflow. And that's what I like about it. I always talk about digital workflow in that sense. Hey, technology is not just there to make things cooler. Technology actually allows us to simplify things, but in a safe way. You and I were talking about that Albert Einstein quote that says everything needs to be made as simple as possible, but not simpler. So simply doesn't mean that, hey, this is just, oh, it's an easy problem. No, it is a very complex disease. And the beauty of Matrix Plus is the test is it is taking into consideration the system that you were just discussing, John. Different phenotypes, different ages, and all that. You don't have to think about it as an individual dentist. As a matter of fact, the test is not looking, although a lot of people think about that mandibular position that we look at, the mandibular position is just a way of us looking at 260 different variables that we get out of that test. And it is the artificial intelligence and the machine learning that allows us to actually study the whole system and spit out an answer for you that simplifies this complex disease. So I want to really make sure we don't have to spend a lot of time on trying to understand every little notice of it, unless you're a scientist, you like research. As clinicians, we want to go out there and we want to make sure we're using evidence-based technologies that are going to do that job for us. And that's what technology actually does.
I would, and let me just put a twist on that. It also, Matrix Plus is a sleep test.
Yeah.
And it turns out that's the only way we've been able to gather evidence that's relevant, that's predictive. So think about what you would like to do. What you'd really like to do is a cone beam on everybody and decide whether they were going to be a good candidate for your therapy and where to set their mandible. Well, it turns out, folks, it doesn't do the job. Mm-hmm. And so if you're going to go that way, you're guessing. You're guessing. The evidence is that it does not predict. Or you may say, I like some other wakeful features of this guy, like how fat he is, or how he sleeps. How does he tell me? How sleepy is he? And so on. No. Similarly, how severe is the sleep apnea? If he has a high AHI, I bet he's going to need a lot of protrusion. Not so. So all these things that you might think would be good, that might be helpful, are not. They're not, and we know they're not. And so be careful when you're guessing. You're probably being misled, is my point, and you better stick with something that's done during sleep that mimics exactly what the custom oral appliance does.
Yeah.
It just pulls the mandible out in an AP dimension, and so this mimics that and provides the evidence that can be utilized by an artificial intelligence to make a reliable, but not perfect prediction. We can be wrong. We have some false negatives. We don't have any false positives. We have some false negatives.
No, it's basically what I'm hearing is sleep apnea is a disease that happens during the sleep, needs to be diagnosed during the sleep, needs to be treatment planned during the sleep, and needs to be treated during the sleep.
Right.
That's very important to remember. That's why it's called the sleep apnea, not daytime apneas. Or I always say that in my courses, and that's very important. It is, as of today, that's the only thing we have, right? We have a lot of questions here, John, but there's one that I do want to wrap up with. There's another question about training and how do we learn more. I'll talk about that briefly. But there is one here from Robert Lang asking, how does it account for opening vertical dimension? That's a question that comes up quite often. How does Matrix Plus take vertical dimension into consideration? That could be a lecture on its own, John.
But I think it's for you. I would like you to do this. So, but all we know is that that's controversial. You might some people are convinced that it's always a help, but it can be said it's controversial. But Suresh, this is for you, please.
Okay, well, I'm going to try to keep this one simple. When I look at it, first, as John said, from research perspective, when we look at the studies that have been done, the jury's out on that one. We don't know exactly which direction it is. There are some studies that shows any vertical between 4 to 8 is similar effects. If it's anything more than 8 millimeters, it could have negative consequences on the vertical. So as of today, there is no consensus as to what is the systematic effect of vertical dimension on maintenance of airway. I'm being very particular in my wording here. It doesn't mean vertical does not matter in oral appliance therapy. When we make an appliance, I always look at it in two perspectives. Is it going to maintain the airway and get rid of the sleep apnea? One. Two, is it going to be comfortable enough for the patient to wear it? And comfort, we're talking about proper muscle position, proper joint position, proper occlusal, lip competency, and all that. To me, vertical matters a lot as of today in that sense. And I do spend a lot of time in the bite registration capturing the right vertical so the joint muscles and everything else is in the proper position. In terms of opening the airway, I don't worry about that too much for two reasons. One, the data is just very inconclusive. And two, what I'm seeing in my clinic, 70% of my patients are being predicted as responders and will respond to oral appliance therapy without me having to mess around with the vertical. Let me repeat this. Out of 100 people, as of yesterday, I used to get 5 or 10 patients that would get oral appliance therapy. And out of those 10 people, only 7 of them were going to actually respond to oral appliance therapy. So I used to use every techniques and trial and error. There's nothing wrong with that, but that's what we used to do to figure out how I'm going to optimize the patient for that 10. Today, the same 100 people, 70 of them, I am going to be able to treat them with only AP position. And then I can worry about the vertical for my, what I like to call it, dental and joint and comfort perspective. So I don't worry about it as much unless we're talking about the very complex cases, which we're not going to discuss today. The other thing I do want to mention, of course, the test has the capability of you being able to test the patient at different verticals if you wanted to. If you feel like your appliance is going to be made at 8 millimeter separation, you can use, you don't have to get the patient to bite all the way into the tray. So if you wanted to test them at different verticals, it doesn't titrate vertically, but you can do the titrations at different vertical dimensions. And I'll just leave it at that. As I said, I can talk about that item for an hour or more, but always differentiate. Is it going to keep the airway and get rid of the sleep apnea? And is it going to be comfortable? And those two things are important.
It's also important to understand that when you are doing a blind titration and just moving a custom appliance out, that you may get fooled. You may think that you have a non-responder because you've over protruded, and it turns out, again, here's the complex system. If you unobstruct somebody with a high gain, the high loop gain, you'll find that when you protrude their mandible and unobstruct them, that their AHI will go up. Okay,
Yeah.
this is you might call it the paradoxical response. People people have known this and seen it, but I don't think they've realized how common it is. We realize how we see it a lot. We really realize how common it is, and so it's important to know that the problem is not that you've over protruded somebody who's now got who has a high loop gain and is now showing sleep apnea again, even though you've unobstructed them.
It's amazing how clouded our judgment can sometimes get, John. Clinically, when you want a treatment to work so hard and we're throwing everything at it, and once it works, we kind of just utilize these conclusions that, well, it might have been vertical. I'm not saying vertical doesn't have a role, but sometimes I feel like the blinded titration kind of guides us in funny hypothetical hypothesizing and portraying it as facts. But let's just move with that. We are about 10 minutes over time already. There are some other questions. I can promise you our team is going to get back to you on that one. John, myself, and somebody from Zephyr will definitely respond to your questions. There was a question about where we can learn more about Matrix Plus. We do have a great customer success and onboarding team. So if you are interested, make sure you get in touch with our team and they will be able to answer a lot of questions. If you're talking about training and actual clinical workflows, we do have different faculty members that do teach these courses in their own way of teaching sleep. Again, our team would be able to help you with that. Some great instructors that will be able to help you with how they're utilizing Matrix Plus in their clinics. I personally have an online course. I think there might be a slide on that one. I'm not really sure. That if you're interested in learning more, we kind of put the platform online, which would be a great introduction for your new protocols of treating sleep apnea. We call it a smart care protocol. Yeah, there we go. We do have a slide here on that one. The next course starts on July 25th. Again, our team at Zephyr will be able to help you with this as well. Our first course was great. We had a lot of live training sessions. But with that being said, I'd like to thank you everybody for joining us. Great question, and sorry we couldn't go through all of them, but we will get back to you. I want to thank you, John, again, and if you want to add some closing comments, that would be good.
Oh, no, only thanks for attending and stay safe. And anything we can do to facilitate your treatment of patients with sleep apnea, we'll do it. We're trying to change the world one dentist at a time. So we're here for you.
Yeah, we're here to support you. With that being said, enjoy your evening and stay safe out there. Have a good night, everybody.
Thank you. Good night.
Thank you, John.